Hey everybody, thanks for joining us today. We have Dr. Peter Haigh with us, who is on faculty in cardiology, which is a division of internal medicine. We've done a couple of these recordings so far with program directors in relatively competitive residencies. And then I immediately heard from students, Dr. Haigh, who were saying, what about if I want to do a relatively competitive fellowship? And some of our incoming students may not even really know what fellowship is yet, or how you try to strategize in the long term, not only for residency, but then looking ahead to a fellowship where there might be a good bit of research or other kind of CV building that might be important. So thanks for joining us today. Can you share anything you'd like to about yourself?
Yeah, Lillian, thanks for having me. I think this is a great stage for students to hear a little bit more about the process. So I'm from Indianapolis and I went to IU for med school. You'll have to forgive me for that. And then I floated up to Wisconsin where I attended University of Wisconsin in Madison. That's where I did my internal medicine training. And I stayed on for fellowship there. After that, after graduating, I was recruited to UK, and so I started my first faculty position here at UK about 3 years ago. And sort of when I joined, I was asked to be part of the core faculty for the fellowship program here.
And I'm so glad you bring this up because students sometimes have no idea who or what is evaluating their application for residency or fellowship. Can you share a bit more about what core faculty is? And students, this is something that exists not just in cardiology, but across a lot of different specialties.
Yeah, that's a good point, Lillian. So I'm also core faculty for the residency. I stepped into that role a little over a year ago. So core faculty basically means that you're a faculty member that's interested and participates in the education and structural process for the training program. So for the residency, I attend leadership meetings. I'm asked to give talks, and I'm a mentor for many of our residents. And I sit in on resident evaluation committees, and then I'm involved in the interview process, less so with screening applications, and more so with interviewing and ranking candidates when it comes time for that in the year.
And if we can take a little side quest here, when you talk about ranking candidates, again, something where students probably have no idea what that is. It's literally core faculty deciding where to rank everyone who interviewed. Any insight on what that actually is?
Yeah, sure. So, most programs, I can speak to cardiology here and our residency. If you were an interviewer, asked to be an interviewer, then generally you're invited to a meeting or a series of meetings where we go through every single person we interviewed, and we ultimately create our list of people that we hope would join us for training in the following academic year. Every place does it a little bit differently, but at the end of the day, you have to rank everybody from one to however many people you rank. And as you may or may not know, that the applicant does the same thing where they rank all the places they interviewed, and then there's this big algorithm that sorts it all out. Um, so there's obviously quite a bit of that goes into that, and it's a lengthy process because we want to be fair and equitable and make sure that we get a good class coming in that we feel like we can work with and that will succeed here.
I like hearing and emphasizing kind of the human side of it, though. Like if students are trying to CV build, ultimately they want someone in that room who's advocating that they stood out in some way or at least didn't have any red flags, and that's probably going to have a big impact, right?
Yeah, definitely. So, certainly there's things that we look at that we value. Speaking from the internal medicine side of things, clinical prowess is the phrase that I hear quite often. So we want students that have shown potential that they will become great doctors. Um, and so that's going to be a little bit different depending on where you go. For example, other programs that are more research and scholarly focused might care a bit more, put a bit more stock into how many publications and how much have they been involved in research. At UK, I don't think there's we care about that stuff. That shows that you've come to work and you've been a student and not just showing up for your courses and taking your exams, but you really bought into the whole process of being a physician scientist or a physician educator or whatever it may be. So that's really important. And then on the interview day, for a lot of that is just to make sure that this is somebody that we feel like we can connect with, that we can mentor and help them grow. You just don't want somebody that's going to get here and totally be a brick wall that we can't learn from, that patients can't connect to, that sort of thing.
That's great insight. I'm gonna zoom way out here. I hear from first and second year med students saying, "Dr. Sims, how much research do I do, or when do I start?" And if they're looking ahead to a fellowship like cardiology, which students is all the way after 3 years of internal medicine residency, they're hearing that it's more competitive, but they don't necessarily know what that means. Can you give a little bit of insight? Why would cardiology be viewed as competitive, and what kinds of maybe metrics or things might matter at the fellowship application level that some students might be thinking way ahead about and wondering about?
Yeah, you're right. Cardiology is one of the more competitive subspecialties out of internal medicine. You think about cardiology, GI's up there. I believe hemonc has also gotten quite competitive. So these are specialties that do take a little extra effort to match into. Match statistics from the last year showed that only about 2/3 of people matched into cardiology. Now that number is going to be a little more favorable if you're coming from academic medical center, and there's lots of other things that you can drill down into that number. But the point is that if you want to do something like cardiology, you do need to put in some effort and have a plan. So I started talking to residents as interns, usually a few months after they arrive here, if they've shown an interest or declared an interest in cardiology, to help set them up. And we see interns come in with a very impressive CV on day one, and some interns who come in who have almost nothing since college. They just haven't really gotten very evolved in their medical school years, and that's okay. I think just like we talked about residency, there are cardiology programs that are very research centric. Some of them are like a 2 and 2, 2 years of research, 2 years of clinical cardiology. Of course, if that's your goal, then having lots of research experience and publications and high impact journals, that's going to be much more important. At UK, we are not super research heavy. We don't have a dedicated research year, research track, but cardiology is a specialty that has tons of medical literature. And so for me, I want a fellow that has done more than show up every day for work and residency and understands the literature and the process of publishing. So if you can get involved with things as a med student, great. That sets you up one leg ahead when you start residency, because medical school is busy, but guess what? Residency is as busy, or if not busier, which I couldn't believe that when people told me that as a student, but that's just the way it is. For me, though, I would say um, do not take on more research or scholarly work that it starts to impact your rotations and exam scores. So only if you have the bandwidth to do that stuff should you pursue it. What's most important is you do a good job in your rotations, you pass your exams, you get good scores on your exams. Because if you fail a course or fail exam, it's going to be way harder to match into a competitive fellowship than if you were to come in without any research on day one of residency. So a whole lot there. So you want me to unpack a little bit more of that, be happy to, but there's not a simple answer, I guess, for everybody on that.
So we're starting at the beginning here, and our audience is, early medical students. Do you see students start a project during med school and continue it during residency, assuming maybe they're at the same institution? Or are you seeing a big divide where they do what they can as med students and then jump into entirely new things as residents? Just for those who are starting to think, what do I get involved in and how longitudinal should it be?
Yeah, I haven't seen that a lot where I see a student that carries a project through residency. I'll see that often in our residents carrying into fellowship, but not as often students into residency. And I think a few reasons for that. I think it's very common that you match outside of where you went to medical school. Um, and the other thing is a lot of times students, it's so early on, people are still figuring out what kind of doctor they want to be. And so often you'll start doing a project, your interests change, you do another project, and that's fine. Um, a lot of really big projects like that take multiple years, those are great. But I got to say, most of our residents are not doing projects that are quite that extensive that take multiple years to carry out.
I'm sure that's reassuring to some of our future listeners. Another thing that comes up a lot with early medical students is they're saying, I think I want to do internal medicine and maybe a subspecialty. They understandably do not know yet. How do you view students' involvement during medical school? Let's say all their involvement was GI research or something else that has nothing to do with cardiology. Are they then on a clock to make sure they publish in cardiology? Is it more just any type of research, or how should they be balancing that, especially if they're undecided early on?
Yeah, we see this a lot and interviewing for a fellowship where they're in residency and they have all this work in GI or pulmonary care, and then at some point they decide, no, I want to do cardiology, and so a lot of times their portfolio shows a lot of research in that other field, and then maybe they've done a couple things in cardiology late on in their training, and that's okay. So if you are applying to a really research heavy fellowship, they might want you to have specific research in cardiology they can then build off of. But I think that's less common. I think for my sake, I am more interested that somebody has shown the initiative, the effort, the desire to come in, do some research projects, and then learn from them. So if it's 15 case reports, that's fine, but I'd almost put more stock in one or two higher level research projects where you're first author, you had a big role in the project. And I will ask people during interviews, what did you learn from that project? And I'm less interested in, what they learned about diastolic dysfunction and mitral stenosis, and more interested in, the process that they learned about research and scholarly work.
This is really great to hear. So if you did something that has no relevance to the specialty you pick, you just frame it based on the skills you built, the lessons you learned, how it shows off your character or your work ethic. It's not something you have to like sweep under the rug because it was the wrong topic, right?
No, I'd say, yeah, I'd like to see something in cardiology. But if you decide late on, it's understandable that if some of your big work is not in that area.
You mentioned sort of higher level projects, and this can be scary for students. It's relatively easy to join and be fifth author on a chart review project or on a case report. Any pointers based on maybe students you've seen or work you've done for how students can find or undertake kind of their big projects, assuming they have the academic bandwidth and the time to do a little more? That can be daunting to even know like what to look for.
Yeah, I think it's okay if a student's not first author. In fact, I wouldn't really expect that unless they've done some preclinical years where they've done bench work or research years before going to medical school. So I really don't expect that, particularly with more clinical research where you are going through charts, you're answering a clinical question. Being first author is probably not something you're going to very often see until you're really a resident or a fellow. So I'm not so much worried about that. But if they can tell me about the project and what they learned from it and what their role was, and if it was just mining data, okay, that's a little bit less impressive than if they had a hand in actually writing the manuscript, for example. Finding projects is tough. I won't sugarcoat that. It's hard even for our residents to get on big projects. We just don't have a ton of people that are doing work like that and have the bandwidth to be a research mentor to lots of residents because cardiology is pretty popular here. So there's a whole bunch of people looking for work already. So don't get discouraged if you're a student and are having trouble there. Case reports are a good way to kind of get your foot in the door too. So you see a really interesting case when you're on your cardiology rotation. Ask your resident, ask your attending, ask your fellow, hey, do you think we could publish this together as a case report? And that's usually an easy thing to do to get to know somebody in the division, and you get to go to a meeting sometimes where it's presented. So that's a really good way to get started with scholarly work.
Right, that's great advice. Thank you. If I can ask about your personal backstory a little bit more, students a lot of times are saying, I want to know, I want to pick my thing. How early on did you know you wanted to do cardiology? And any advice for those who are maybe shadowing or looking for mentors, trying to kind of narrow it down as early as they can so they feel a little more decided?
Yeah, I personally was interested in cardiology early on in medical school, and even before then, I had a family friend that I worked in their office in the summers, did EKGs and things like that. So, but I was really close to applying to a couple other specialties along the way, and ended up deciding that I really liked internal medicine and even while in internal medicine, I thought about pulmonary care for a little while. I thought about hospital medicine for a little while. Um, and then even within cardiology, there's a whole bunch of different cardiologists. And so, I went back and forth between a couple of subspecialties within cardiology. So it's normal to waffle a little bit and go back and forth. That's good. That shows that you have an open mind, in my opinion. Um, so I'd say if you kind of know early on, that's great. Don't fall in the trap of just because you get along really well with one person. Do you just like that person, or do you actually like the field? So, just be a little thoughtful about that distinction.
Oh, that's a great point. And last question, just to make sure we haven't missed anything that would be great insight. Times that you've seen research really shine on an applicant's, interview or in their application, or times where things have not gone well, they probably haven't been perceived the way a student intended, red flags, that kind of thing. Anything else that hasn't come up that might be helpful insight?
Sure. I think more so from the fellowship standpoint, interviewing residents. A lot of times I'll see residents who have come in and done really cool projects. And if it's something that I have a shared interest in, we'll talk about it. It's more of a conversation. I'm not trying to quiz them, but um, sometimes they teach me something in the interview about an element of cardiology, or they'll make me think about something in a certain way I haven't thought of before. So that's always really fun when we can have a cool conversation about a shared interest. The one thing you don't want to do is kind of overstate or stretch the truth about your involvement. And then if that happens to come up in an interview, yeah, it can make the applicant look disingenuous or at the worst lying. So that would be a red flag during an interview. If I start asking somebody about a project and they're not able to tell me, anything about it, or come to learn that, they really didn't do anything. They just kind of put their name on it. So those are things that you don't like to see. So don't lie during interviews, and if you aren't sure whether you can speak about it, maybe don't put it on your CV, because if it's on your CV, it's fair game to come up in an interview. I'd say that's very uncommon that I see something like that, but it does happen. So it's great to have a big CV with lots of publications, but don't stretch the truth on anything.
This may be more relevant to your role with internal medicine than cardiology, but certainly my perception in the last few years is a shift more towards emphasizing quality over quantity. You know, step went past fail, and I feel like students were just throwing everything they could on their applications. And now we're seeing a little better emphasis on meaningful roles or sort of in-depth effort. But I like hearing that you're giving them permission to not have the longest application or the longest list of outcomes, right? It's not just a number that they're aiming for.
No, I don't think there's a set number. It's great if they have, you know, a couple of projects that are really cool. They had a big role in it. They learned something. We'll talk about it. You know, for me, that's more important. I think other programs that really expect them to come in and do a lot of research, you know, grant funding, they might value that more, not just having quality, but also quantity. But that's really not something that we get too bent out of shape about here at UK.
That's a great way to frame it. Quality is a foundation regardless. For some programs, you may also need quantity, but never just just the numbers. All right. Thank you so much, Dr. Haig. We really appreciate your time and your insight.
Right. Thanks for having me.